Well, hello again, RT listeners, and welcome to episode 4 of RT Matters. I'm Patrick Dunn, your host, and we're really excited to this episode. We're going to talk about something that's very important for our profession going forward, and that is de-implementing low-value respiratory care. Now, before we get to our topic and I introduce our special guest, let me give you a few housekeeping bits of information. First of all episodes of RT Matters are available on our dedicated website, RTMatters.com. It's open access, no charge, no subscription fee. And you'll notice when you go onto the homepage, up on the left-hand side of the masthead next to the logo, there's a link, Send Your Feedback. We just added that because we want to hear from you, our listeners. We want to hear your thoughts about prior episodes, what you think we can do better, and more important, topics of interest to you as a respiratory therapist. RT Matters is here to serve as a sounding board for all respiratory therapists and eventually become the virtual voice of RT everywhere. So it's rtmatters.com. Now, today's topic, de-implementing low-value respiratory care, I want to give you a little background about how I first got involved with this topic. And it happened back in 2020 when I read an article in the New England Journal of Medicine authored by several members of the Duke Margolis Center for Health Policy and a former director of Centers for Medicare and Services, Dr. Mark McClellan. Low-value care, they described, the topic of the article was building a better healthcare system post-COVID-19, steps for reducing low-value and wasteful care. Low-value care, they described as procedures or treatments that incur costs but provide little to no clinical benefit. They accuse them of being wasteful, potentially harmful, and very, very pervasive, accounting for anywhere from 10 to 20% of annual healthcare spending. And it's pervasive throughout healthcare. Basically, you see articles in the Journal of Clinical Care. You see them in practice of trauma care, low-value care and endocrinology, low-value care in traditional Medicare fee-for-service, low-value care in the military healthcare system. So an awful lot of the other disciplines in medicine are talking about low-value care. Now, as it turns out, most low-value care, as we're going to find out from our guest today, the clinical practices and procedures are not supported by high-quality evidence. And we also went on to find out that when you do and you have characteristics of low-value care, it's also known as overtreatment. Like I said, it's necessary, non-purposeful, wasteful, lacking credible evidence, and more importantly, eliminating won't compromise the patient's health care outcomes. The articles went on to say this is driven primarily by prescriber biases. They have a comfort levelness with this procedure. It's institutional culture, informational disparities, and concerns over litigation. So that brings me to our guest today. I'd like to introduce you to Kellianne Fleming. She is a registered respiratory therapist. She has her specialty credential in neonatal pediatric and adult acute care. She is now the director of Pulmonary Services at Froedtert and Medical College of Wisconsin, located in Milwaukee, Wisconsin. And someone once said, if you want something done, give it to a busy person, and she fits that bill. She's also the interim director at Froedtert's Bluemound Rehab Hospital. Now, one of the points that we have at RT Matters with our invited guests, first of all, Kellianne, welcome to our RT Matters. We're glad to have you.
Well, thanks for having me. I'm excited to be here.
We're excited to have you, and we'll see more about why we're so excited. But before we start our actual focus on the content, we always wanted our invited guests to share with them their journey into respiratory care. We always want to address the fact that this is indeed not a dead-end career, as some people think. So before we start, could you share with listeners how you first learned about respiratory therapy?
Sure. So I am a second career respiratory therapist. I have a bachelor's degree in communications, and I had some jobs in radio and TV ad sales and beer sales, and I've done the whole gamut. But essentially, I was looking for a career that could be flexible. And I knew I always liked biology. And so I kind of shifted gears. I had 4 little kids at the time, and I was specifically looking for a job where I could get health insurance for my family because my husband was self-employed, and do something that was meaningful, something I enjoyed, and something that was financially lucrative. So I went online and I started searching medical careers, thought about being a nurse, went to the nurse open house, located the respiratory therapy open house as well. And I will tell you, I'm going to give a little plug to the director of clinical education from my respiratory care program, Christine Anderson, was so enthusiastic and so energetic and really just had a passion for respiratory care and how we can make an impact in people's lives that was sometimes overlooked because we always think medical, doctor, nurse, right? Doctor, nurse, APP or PA. That really flipped it. I was thinking I was going to go into nursing, but that really flipped it for me.
Well, that's good to hear. You already had your bachelor's degree in communications, I understand, but you went back to school and got your AA's degree in respiratory therapy in 2007. But however, once again, you returned to school in 2017, obtaining your master's degree from Rush University in respiratory care. What prompted you to continue on further beyond your baccalaureate degree?
Because I really wanted to be good at what I did. And I had, met some people from Rush who had gone through the master's program who really encouraged me to look into it a little bit further. But essentially, I wanted to really own my skill, own my craft, and be the best at respiratory care that I could be. And I thought that would be my next level up. And additionally, right, getting that next level up in education opens up more doors for you in terms of career path.
No question about it. And I also noticed in your career early on, you joined both the AARC and the Illinois State Society for Respiratory Care, and you still serve on numerous committees in both organizations, including the Wisconsin Society. What prompted you to volunteer your time? You've gone to school, you have a family, you have a job, and yet you still volunteer your time for these professional organizations.
Well, the logical answer is you always want to give back, right? You want to give back to the organizations that's for you and your peers and your career, but also just to be connected. I've learned so much through just the process of being on committees, not just about respiratory care, but about how to run a committee, right? How to do all those things, how to connect, how to network, all those things that, again, give you a nice base to build your career off of.
Yeah, no question about it. I found that to be the same when I got very involved with the California Society and later on with the American Association. You associate with peers who are in the same profession but work in a completely different environment. No two hospitals are the same, so you learn a lot of flexibility. Another noteworthy professional activity I noticed since 2012 is that you participate in clinical studies and you publish your results in peer-reviewed journals. What motivated you to undertake this other aspect of your career in terms of being a published author?
Oh, you know what? I love it because, I was brought the opportunity, and at first it was very daunting, right? My first publication was a chapter, actually, which was very daunting initially. But you're never going to, I guess I should say, you have to take those opportunities. As daunting as they are, you're never going to become a writer or a published writer if you don't at least give it a shot, right? So you just kind of throw yourself out there. And that's kind of how I live my life in general, right? Sure. You just kind of say yes and keep going. But, and as we get into some of the quality initiatives and things that I've published, if you didn't publish it, you didn't do it. And there's a lot of good information that you want to share with everybody else. Well,
there's no question that when you publish and write something and submit it for others to review in a peer review process, you become a much better writer, but you also become much clearer in your thinking, which is, like you say, something that really allows you to go forward.
Yeah.
Let's move on to our topic for this episode, and that's the reasons for you and your team at Froedtert to go into this de-implementation of low-value respiratory care. What really was the motivation behind that step that you took?
Two things. One, I was new in my role as director previous to COVID, about 9 months before COVID. And we had a staffing issue then, right? We still didn't have enough respiratory therapists. My respiratory therapists were really getting run ragged. They kept saying they had so many nebs. Oh my gosh, all this floor work and a lot of rumbling about how many nebulizers they were doing. So as I started to dig into that, COVID hit.
So it was really prompted by the fact that you were relying on a lot of travelers, very expensive for the hospital, and a lot of treatments. Now, I've always been of the opinion, especially since I worked with the Joint Commission years ago, that a prescribed order in the hospital for a medication, if it's not given, it's really a medication error, unless the patient is not available for other purposes or the patient refuses. Mm-hmm. But short staffing isn't a reason to not give a treatment. So you're probably being hit with a lot of your QI department having frustration with missed treatments.
There are a ton of safety events, right? Documented all safety events. Mm-hmm.
Now, when you lost about the pervasiveness, you actually did a literature search. And what did you find when you did your literature search? Probably something similar to what I mentioned at the beginning of the program. And I commend you for going independently in that same direction.
Yes. Yeah. So initially, right, we were looking specifically at two medications. Mucomist, acetylcysteine, and also 3% hypertonic saline, because we identified in our workload that that was really the majority of the nebs we were doing. So we were looking specific for evidence for those two drugs. And in doing so, then we, the AARC and the clinical practice guidelines, right? All the evidence was right there.
Yeah, we'll talk about that in a moment, but I also want to let our listeners know that you actually published your findings in the May 2023 issue of Respiratory Care, and that's where I first found out about what your project was. And I called you and talked to you because one of the points that you raised early in your paper was this notion of confirmation bias, which I call entrenched interests that kind of get in the way of innovation. And I told you I was very surprised to see you. What did you think, and how'd you happen upon this human behavior that often impedes innovation, confirmation bias?
Well, as we looked through the literature and we're looking at the de-implementation process, that was one of the points that was brought forward in the papers we were reading, confirmation bias. And then you can so connect it to what you see every day at the bedside, right? We've been seeing confirmation bias our whole careers, but I had never had a name attached to it. So it was really enlightening and validating to know that this was actually, for lack of a better term, somewhat of a human phenomenon, right? That we all have confirmation bias. So yeah, it was really enlightening.
Yeah, in some respects, confirmation bias is healthy. Like if you have your thoughts about your religion, your political persuasion, your social life. The bottom line is that sometimes confirmation bias gets in the way of listening to new information that goes against what your feeling is. And it's an instantaneous turnoff. And of course, that's really a big obstacle when you're trying to do something that's very, very highly innovative in a very disruptive society, which was COVID. Now, at the same time, you mentioned that your team focused on one particular aspect, which was the nebulization of 3% hypertonic saline and mucomist and acetylcysteine for airway secretion clearance. And you went to decide if there was evidence for this. And you mentioned earlier the CPG from the AARC. Tell us how you happened upon that project.
Well, again, right where we had to get rid of these travelers. Not that we ever got rid of them, but we were able to reduce the number of travelers we needed. We were able to close that staffing gap by by eliminating those non-indicated treatments like 3% and the hypertonic saline and the mucomist, essentially. So when we looked at how many we were doing, we reduced it, now I can't come up with the percentage, but I know you get this out. We reduced it and we were able to save the equivalent of 6.7 FTEs.
I want to point out that was not because you eliminated the positions, but you just didn't have to fill those positions or temporarily fill them with travelers. And again, nothing against travelers, but at the same time, you want to have your own dedicated team on board in place all the time.
We also were able to implement a dedicated rapid response therapist out of that. So that was really helpful.
Now, also, it seems like you determined that your research, especially with the clinical practice guideline, fulfilled all the criteria we talked about earlier about this being overprescribed, being pretty much a routine of prior training that the physician prescribers saw, little or no value, and at the same time, you going up against a very heavy confirmation bias. And I noticed what you did is you made it a hospital-wide QI improvement initiative. I think that's another stroke of genius. It wasn't respiratory care. It was the hospital-wide safety initiative. Could you tell us more about how you approached your QI department and got them involved?
Yeah, well, we have a value-based care initiative, so a committee just for value-based care, and that's where I brought it. I'm lucky enough to have a seat at that table and engage that value-based care committee, and they were always looking for opportunities just like this, so they latched right on, and they also helped to, enlighten us on the best way to get it done. That would be a nice giant blanket movement across the organization. So I had that support behind it, which made it so much more efficient and effective to roll out.
Right. But you also had then with a legacy of mistreatments and all of those other safety issues that we looked at earlier. So you were kind of going right in and saying, here's the problem, and here's what we'd like to do to solve it. And I think that really is kind of how you got that full-on support for an institution. Right. Now, another question, how about your initial staff misgivings? You always talk about your team. Yeah. I'm sure some of your staff members were saying, whoa, what are we doing here?
Yes, they were real leery, to say the least. They're like, now, wait a minute. So we can discontinue the treatment if it's not indicated? And I said, yes, after you communicate with the physician or the ordering provider, right? You have to have that closed loop communication and be respectful and build that partnership. I can't tell you, we made so many copies of the clinical practice guidelines that we handed out to physicians and residents in real-time training right at the bedside when we would have those conversations. The team kept coming back and saying, can I get more copies of that? Can I get more copies of that? So it was an education for everybody.
If I'm not mistaken, that was one of the earlier clinical practice guidelines that went from expert opinion to the evidence base. So there was strong evidence in that particular document, which allowed you to freely distribute it and feel comfortable for it.
Yeah, 100%. Yeah, it was great. It was great. And you know, the providers were very appreciative of it, to be honest, especially if you can get those residents, you know, teach them early.
Yeah. Now, I noticed that one of your co-authors on the article is Dr. Froedtert, your medical director. Now, you also reached out to the medical staff, and I'm sure you got some experiences that you'd like to share with us about that. And again, not being disrespectful, but remember, confirmation bias is in everyone. And I'm sure some of your physician colleagues at the medical staff were kind of taken back by the radical nature of your proposal.
Yeah, and that's what was really nice about having a physician partner in Dr. Truitt, and then also having our CMO on board. So we took this all the way up to the medical executive committee. So I had the physicians at the higher level who had already seen it before I had to roll it out to the physicians at the bedside. But yes, there was a lot of, you know, we will track and we'll see what our ICU bounce backs are and our mucus plugging, and patients are going to be dropping dead because their trach is plugged because they didn't get their 3%. And I said, well, then, you know what? We will change course if that happens.
So you also were very accommodating, but still, I'm sure you met with some obstinate feedback that you can't do this. And I guess the QI initiative probably helped solve that problem in some respects, although there are probably still some physicians who probably aren't on board.
For sure. And to this day, and I'm still sharing information and papers with the physicians. But I will also say, right, you have to come from a place of humility when you have those conversations with those physicians who don't necessarily want to buy in, right? That's part of that confirmation bias. There's ego involved in that. So you really need to kind of take a step back, listen to their concerns, show them the evidence, and then just continue to show them the evidence, the consistency.
I think some of the traits that you mentioned, you want to be persistent, but you also want to be respectful. And you actually, I believe, gave some physician, any physician that wanted to be able to opt out if they wanted to. And we'll talk about what the findings were downstream that you saw, surprisingly. But did that allow some of the physicians to feel a little bit more comfortable that they could actually opt out if they felt that this was something they really wanted for their patients?
Yes. They did. And, you know, you have to make those constellations, right? You have to pick your battles, just like with anything else.
All right. Now we're going to take a break right here, and we'll be right back after a short pause. All right. We're back. I'm Patrick Dunn. I'm the host of RTMatters, and joining me today is Kellianne Fleming, and we're talking about her initiative to reduce the incidence of low-value respiratory care at her facility in Froedtert, Wisconsin, Froedtert Medical Center in Milwaukee, Wisconsin. Let's talk about the effect that you implemented. And one thing you pointed out in your paper was that this was a long process. It did not happen overnight. And some people lose their patience with long processes. And I guess the fact that it was an ongoing QI initiative really probably was a cloak, in a sheep in wolf's clothing in some respects, because it allowed you to kind of, use the existing system to make innovative change.
Right. And you have to monitor it all the time. So we monitor it every month. We notice if there's been peaks, and then we actually go back and drill down, right? Like, why is there so many, hypertonic salines and mucos in CVICU? Well, one of the exceptions you spoke of before, right? We made a little exception for our lung transplant patients. They want to do a little muco and hypertonic saline post-surgery. We'll allow that. We know they're not going to be here in a specific population. But we want to make sure we're tracking that.
Okay. Now, you have probably interns and residents and fellows at your facility, physicians in training. I would imagine that would be a nice, easy way to make them feel more comfortable when they finished and go elsewhere. Are you seeing any of that follow-up from other institutions contacting you when some of these physicians that you've trained move on to other facilities?
Well, not necessarily from the physician standpoint, but definitely from the publication. We've had other departments reach out to get more information on how we rolled it out, how we got our evidence, how we got the buy-in for the policy, and all of that change management work we did. A lot of interest in that.
Well, that's what's important is that the publication that we mentioned earlier allows you to share your best practices with other institutions. And the fact that it's in a peer-reviewed journal gives it credibility of the highest level, that's for sure. Now, one of the things that we noticed that there was a change in physician behavior, and you pointed that out in the end of your article under the discussion that after about 3 or 4 months of implementation, you started to see another trend. And I'd like you to describe that for our listeners.
I don't know what term, what you're speaking.
The physician ordering of the hypertonic saline, and
that it dropped.
Yeah.
Yes. Okay. Sorry about that.
That's all right. No problem. No,
yeah.
We're here to discuss conversation.
Right. Yes. No, we did. We saw a decrease in the orders overall, which was really great. Right. So we changed the practice. It takes time and consistency, consistent messaging, consistent conversation with those physicians that now we have seen a great decrease in the number of orders for sure.
And that basically proves that there is some satisfaction with the new process. Now, how about your staff today after having had this program in place for several years where they can actually make a decision to countermand an order that is not evidence-based? How does that impact the staff morale?
Oh, I mean, it's great. It's really great. And they will bring it up. They'll bring up how even though they're busy now, we may have 60 ventilators running. They will refer back to it's still not as busy as it was when we had all those nebulizers. Or they will say, can you imagine if we were still doing all that hypertonic and mucomist like we were doing before? How would we ever survive? So they have definitely appreciated it, recognized it, feel empowered by it. And I don't hear a lot of complaints about, oh my gosh, there's all these nebs, because they have control over it.
Right.
As you should. They're the experts, right?
Yes. I really share with you this whole concept of being neb jockeys. And one of the terms that I really dislike is breathing treatments. I like to call them therapy sessions. And you're in that therapy session, you're using bronchodilator therapy, or you're using airway clearance therapy, or you're doing a ventilator patient interface check. It's not breathing treatments. The problem I find with that is, and I've said this before, is that some of the consultants out there just see breathing treatments and they go to the administrators and say, look, we can train other people to do that costs less than respiratory therapy. They don't understand what goes into a therapy session when we're giving a bronchodilator to a patient that has respiratory distress.
Right. And, that was one of the things that came up like with COVID and this whole NEB project, right? This de-implementation project. Well, can we get, extenders? And my response to that was, why do you want to have an extender do something that's not evidence-based? Right? We're not getting ahead then. We're still, fostering bad behavior and ineffective treatments.
Yeah. And part of it is being busy, getting your procedures done for your workload. We use antiquated ways to measure performance. So how have you changed from counting procedures ordered versus those given versus those missed? Those were easy numbers to calculate, but it sure, like you said, missed the point that we're giving ineffective therapy. We're doing busy work.
Right, exactly. And why do we want to extend our workforce to do something that's not indicated? It just doesn't make sense.
Now, any other areas that you're looking for to try and drill down on other areas of low-value respiratory care?
Yeah, well, some of the things we're looking at, right? The Q4 albuterol out the door, right?
Funny you should mention that. I was just going to share with you one of the points that I've raised. It appeared in the October 2021 issue of Respiratory Care. It was actually an open form abstract from a group of RTs at the University of Health in San Antonio. And what they did, it called albuterol, often used and heavily abused. And this was right during the shortage of albuterol sulfate for medication purposes. They looked at a retrospective review of 50 electronic medical records of subjects who received at least one treatment of albuterol. And what part of their process, as I mentioned to you earlier, is they do bilateral auscultation and check the breath sounds both before and after the administration of the bronchodilator, in this case, albuterol. And of the 50 subjects that they reviewed, the record they reviewed, 60%, the recording was clear, no obstructed breath sounds prior to and after the treatment. And they went on to say a stricter protocol for albuterol administration may dramatically decrease the misuse of this important medication. And again, the Q4 out the door, that's a euphemism, but it really does. And I've had physicians say, Well, I want someone to see my patient because the nurses aren't around. And how are you dealing with that? It seems to me that's just another one of those areas where we can really make a difference in terms of how we use our staff.
Yeah, 100%. And we have implemented, alongside of almost in tandem with our NEB de-implementation project, a respiratory therapy assess and treat protocol and pathways, but we're trying to get the buy-in for that, right? So in the meantime, we still have all these Q4 out the doors, but we're trying to combat that by getting an assess and treat.
Building on your success with the prior.
Right, and being able to then wean through the pathway.
I always tell people, remind them that if you read the package insert for albuterol, it's for acute bronchospasm, acute episodes of bronchospasm, and it's also to be used for pre-exercise induced asthma. None of our patients recovering from an exacerbation once they're steady state meet either of those criterion.
Right.
So the transition, and there are bronchodilator protocols out there for inpatient use where the idea is after their dyspnea goes down, is abated, and then after their auscultation is improved, you descend, you kind of de-escalate, go from albuterol to a long-acting agent, whether it's a beta agonist or a muscarinic antagonist. Have you toyed with that option in terms of your assess and treat and triage?
Yes, for sure. So we have that all built into our pathways. We have separate pathways per disease process. Yes, for sure.
Now, one of those challenges is, of course, to work with your pharmacist to stock these newer medications, and they look at their budget. And then, of course, you have to show the overall impact on the hospital's budget, which I think is what you did very successfully with your QI initiative.
Right, exactly.
Yeah. Now, any final thoughts on the importance of identifying this low-value care, lessons learned, future areas for consideration? You mentioned albuterol. Anything else that pops up?
Oh, yeah. I mean, we're also looking at how we're managing our high-flow patients. How long do they have to be, are we weaning them appropriately? Are we able to move them through? We're looking at our tracheostomy patients, same thing. And that not just for resources, but also for the patient's well-being and to get them out of the hospital sooner for their quality of life. All those
right.
There's
There's so many opportunities, and it takes an initiative and it takes a team to do it. Do you have RT students rotating through your facility by any chance?
We do, several.
And are they kind of, because they're obviously at other facilities as well that probably don't have that particular approach to, aerosolized medications for airway secretion. How do you kind of take away their concern that what are we doing here? What are we not doing it over there?
Oh, yeah, exactly. And, that's one of those things that we use as a recruitment. Not only, they may not get wholly what that means to them in their day-to-day when they're here as a student, but what they do recognize is that the leadership team and the management in the hospital supports respiratory care. And that's a huge recruitment tool right there.
Yeah, so you probably get a lot of those first that want to stay there after they finish their training and their program. Yeah. Well, the nice thing, you're teaching them the right way out the door. One of the things I'd like to mention is, if we're closing up here, is a mentor many, many years ago, before I could ever care to remember, it sticks with me, said, a good effective leader, when things don't go well, they go sideways or there's an actual failure, the effective leader steps up and takes full responsibility and then leads the charge to fix it. When things go really well and everything is working smoothly, the good leader gives credit to the team that made it happen. And I noticed that you in your posts do that. So you're not only a good clinician, you're a great leader because you always recognize your team. And every time I talk to you, you're always talking about, well, they did this and they did this and they have this poster coming out and they have this presentation. I think that's really nice. And I don't know if that was something you learned at Rush or something you learned instinctively, but it's really the sign of a great, great leader to give credit where credit is due, because a lot of times there's a lot of self-aggrandizement. Look at me, I did this, and this. And no, it's a team.
Yes. Oh, that's really nice for you to say that. And I really do believe that because it seems like it wasn't that long that I was at the bedside, but they are doing the work. They're doing all the work. We're just supporting them along the way. So they absolutely, when we, the team, present these things, we always tell them, we're going to present your work. This is your work. I just happen to write it. I didn't do it. I'm just writing it. So know that it's yours.
Yeah, it's a team. No question fit it. And I think that, like the way that you looked at COVID as a positive, I don't want to underestimate COVID because it was horrible and some of our members paid the ultimate price in taking care of. But one of the nice things about COVID has certainly established the role of the respiratory therapist as a key member of the critical care team. You're moving that respect out of the intensive care unit, which I think is a very important process for our listeners to listen to. It's not all critical care. There's an awful lot of care that's given outside the critical care areas and settings. And the other thing is that COVID, I've had several hospital administrators tell me privately, it's been one of the best change agents ever, because it really forced us to realize that healthcare indeed can make transitions on a pivot. Because prior to COVID, people in the business school would say, don't go into healthcare because they violate every rule of business. You know, there's so much stodginess, there's so much invested in terms of tradition and hierarchies. And basically, COVID showed, yes, you can actually cut down non-essential services. You can redeploy and retrain those professionals. And our profession did that with a lot of physicians in terms of ventilator. And our profession, we pivoted very quickly when we found out that non-invasive ventilation was actually making the patients worse. And all of a sudden, and 3 months later, after the paper was published out of Germany, we're using high-flow nasal cannula. Right. So it really did show that healthcare can indeed pivot. And I'm trying, with your help, to try and get our respiratory care colleagues to recognize that this is a great time to address some of those issues that are holding us back.
Yeah, that is so true. The word nimble we used all the time, right? Have to be nimble, Everything's changing all the time. The access to the executive leaders, doors were wide open. You could call them up. They'd answer the phone. You'd get things done. Super great. But even just for the team here, you know, when I came on, it was like, oh, nothing ever changes. But now we're able to change, right? Yeah. We can move things along. We can fix those things that we're finding error along the way.
I like your enthusiasm, and I guess it reinforces the fact when you have a job that you really like, you don't have a job, you have a career. Yeah. I think that's really, really important. All right, that pretty much brings us to the end of this episode of RT Matters. We want to thank our guest, Kellianne Fleming, and your listeners for tuning in. Now, go out there and be the best possible respiratory therapist you can be. As Kellianne pointed out, our patients deserve no less. And after your shift, always leave your workspace equal to, or in some cases, perhaps better than you found it. Make it a clean, professional, and complete handoff. So until next time, be kind to yourself and to others. And remember, RTs do indeed matter. So take care.